Can I just start by asking, are we justified based on lab tests, CT, and things like that, to jump straight away to use rituximab instead of trying cyclophosphamide and steroids?
Yes, so the question is very clear. Is rituximab something I would use immediately? The answer is yes. I would use it in particular. I would prefer rituximab against cyclophosphamide in the early phase of the disease in young women because of children, because of pregnancy. So I would be very keen to use the rituximab as much as possible, in particular in this population of patients.
Sorry, when you use it, Paul Emery had the vision that he gives it in pulses every 6 months instead, half a gram instead of 1 gram every year. What do you usually do?
Depending on the case, how active is the case, how advanced is the case, usually we prefer in patients who are very active to go high with dosages and prefer 1 or 2 shots instead of keeping them in time. Shots that usually now almost reach 2 grams per square meter. Okay, so 1 or 2. And then maintain with other drugs, like mycophenolate.
Okay.
Any questions?
Sorry, any other questions? Yes, go ahead. Can we have the microphone here?
My question is for Dr. Marco. I have a patient with a linear scleroderma, morphia.
Can you repeat? I'm sorry.
I have a patient with linear scleroderma, morphia.
Okay. So
my question: how to treat those patients, and if there is any possibility that the disease can be systemic, so we have to use immunosuppressive for those patients?
It's very unlikely that a localized scleroderma can become systemic. There are some cases described, but it's very unlikely, hopefully. For linear scleroderma, it depends how much is the extension, which is the age, if they are children or they are grown. Usually they are children. However, if it's just morphia, 1 or 2 patches, you can use methotrexate and steroids. But if it's a linear scleroderma, or it's a coupe de sabre, or is a fascial hemiatrophy, you should be very, very aggressive. The case where you must be aggressive, and even we transplant them, is the generalized morphia that is a terrible disease.
Thank you.
Can I just add one thing? Is dipenicillamine still in use? Dipenicillamine is still in use?
No, because it doesn't work. Very simple answer, doesn't work. So don't waste your time with penicillamine because it's not what you want.
Any other questions? Yes, go ahead.
Using cyclophosphamide, does it affect the stem cell transplant later in those patients with lung interstitial fibrosis?
Okay, excellent question. No, if you are still below 30 grams. For instance, if you have a dosage of 10 grams with cyclophosphamide in pulse therapy or oral therapy, you can still go on with the transplantation. But if you cross the border, you know that the risk is increasing enormously, so you should stay away from cyclophosphamide.
Any more questions? Yes, can we have the microphone here, please?
I have one patient. She used to she has severe joint pain and different diagnoses, and they advised non-steroidal anti-inflammatory, but she is asthmatic. when she takes the anti-inflammatory non-steroid, it will prestate her asthma. And when she take the treatment for asthma, she used to have palpitation with extrasystoles.
Can you repeat them sort of slowly? Because
The question is, this patient, she is asthmatic,
Yes.
and whenever she takes non-steroidal anti-inflammatory drugs, she gets an attack of asthma, right? And when she takes the anti-asthmatic therapy, she gets palpitations and extrasystoles.
So she used to go to local things and keda. If you give me advice, something to use for her.
is this a scleroderma patient?
What?
Is this a scleroderma patient?
No, I don't know. She came to me in the general clinic, usually with this complaint.
What is the diagnosis? I mean, the professional diagnosis. That's all.
They said arthritis. It is vague because what kind of arthritis, really, I don't know.
Okay, so first of all, we have to understand which kind of arthritis is this, I think.
Yes.
You know, methodology, when you look at the patient, is fundamental. So first of all, which kind of arthritis? Is just a reactive arthritis or is a main arthritis? I mean, it's a main disease. So this will lead you down to understand what you're dealing with. Now you're saying that non-steroidal anti-inflammatory drugs that you're using are inducing asthmatic attacks. And the asthmatic therapy, the therapy for asthma, is inducing tachycardia. Is that
Yes.
correct?
Yes.
So the fact that anti-asthmatic therapy induces tachycardia is a normal side effect. You will have this very frequently. So, but the problem is you should not give non-steroidal anti-inflammatory drugs to this patient. So what does it mean? You should make the correct diagnosis.
Yes.
Instead of giving anti-inflammatory drugs, you should give something else. Maybe a little bit of steroids, and this will even avoid asthma because you're using steroids.
I used to give her for short, 1 week, but really, I used to be afraid. I am afraid in using cortisone.
Did you check
for a
antibodies in
lot
this
of-
patient? Did you check the antibodies?
No.
Did you check rheumatoid factor?
Yes.
And
Negative.
negative. And sedimentation rate and CRP?
The sedimentation rate is 40.
So you have an increased sedimentation rate. It means this patient is likely to be inflamed, and you have to check the joints. In which condition are the joints? Are they swollen? Are they tender? Do you have anything with the X-rays to be seen? Any modification? So you have to work a little bit, I think, on this patient.
No, because see, she came to me as a general, as a
Doesn't
family
matter, you are a
physician,
doctor.
But this is not my specialty. I'm trying to convince her to go. She said no.
Send her to the specialist. Send her to the rheumatologist.
I advise her. She said, just give me something to relieve the pain. I'm giving her local gel and local like this and hot fermentation and that's all. So I'm asking, if she...
How old is your
How
patient?
can I help?
How old is she?
She is around 59.
59.
Like
So you
this.
give her acetaminophen, which is Panadol, 2 tablets when necessary. And most probably this patient can be generally osteoarthritis. The other thing, measure the vitamin D. She might have
Vitamin D.
hypovitaminosis. And this will relieve the bony ache she's having and will improve her muscle power. And then, like Professor Cerinic said, do a workout lab for anti-nuclear factor, extractable nuclear engines, exclude other inflammatory conditions. But to be on the safe side, not to induce any asthmatic attacks, use acetaminophen.
Okay. Can I give her directly the vitamin, or I will wait for the report?
If you don't want to wait, do the PTH.
Yes.
And if it is elevated, definitely she has hypovitaminosis or vitamin D insufficiency.
Thank you very much. Thank you.
Probably, if you just have an X-rays, as Samir has said, of the joints, you will see what's going on. Is this really osteoarthritis? With the X-ray, you may have approximately the vision of what's going on and help you.
Any more questions? Yes?
Actually, I have a question of two parts, perhaps, for Dr. Marcus and the other for Dr. Holger. The first is like, I have a patient who is 25-year-old. She has been diagnosed with rheumatoid arthritis, quite severe. She's been on methotrexate and I believe Humira, and for quite a long time. And now she's planning to get pregnant. We have stopped her methotrexate and as well as the Humira for at least 6 months before getting pregnant. The question is that there are other doctors who's been telling her there is no need to stop the Humira. So I want to know your opinion about that.
So, which is, I'm sorry, she stopped methotrexate.
Yeah.
She continues on a Humira.
Yeah. I've asked her to stop both of them because, as I have read from the studies, that there is no, it hasn't been proved whether it is going to do any harm, at least in human beings. There's only in animal studies. But there are other doctors that she has seen in other hospitals who have told her there's no problem in continuing Humira, and she's between these conflicts of two opinions.
So we have to continue on Humira or not? She's taking methotrexate.
Okay, so you withdraw methotrexate, now you have the problem, Humira, continue or not continue before getting pregnant. So which are the facts? Which are the facts? First of all, we don't know what anti-TNF are doing during pregnancy. So we don't know. But however, what we know today is that anti-TNF foster pregnancy very highly. So they induce pregnancy, not induce, I'm sorry, they favor pregnancy because they induce tolerance. So that's the reason why they are able to facilitate pregnancy. So my suggestion in this patient would be keep it until she's pregnant. When she's pregnant, you stop. Because after this, you are not allowed to continue. Some people 4 or 5 years ago would have said, no, stop everything. But the risk, the high risk you have is that the patient will flare up and then you have a problem. So the other advice is keep it and then withdraw it, but use hydroxychloroquine immediately to combine, because you will be able to keep hydroxychloroquine during pregnancy and use steroids, because both of them, hydroxychloroquine and steroids, you will be able to use them during pregnancy, just to keep the patient under control. So wait for Humira. When she's pregnant, you withdraw Humira, but you will continue with hydroxychloroquine and steroids.
Okay, thank you very much. My next
Can I
point-
add one thing? With Humira and anti-NF, generally speaking, there were some reports about the outcome of pregnancy. Children or babies, usually, some of them, they have a cleft palate or hair lip. This is one thing. Like Professor Cerinic said, if you add antimalarials, if you add small dose of steroids, you still can add sulfasalazine. It's an anchor drug during pregnancy and lactation as well.
Thank you very much.
You have another question?
Yeah, it's just a small part actually for Professor Holger. The same patient actually went into arthroscopic therapy for her joint, for both of her joints, shoulder joint, because mainly it's not for the pain as much as it is for the motion. The range of motion was very much restricted before that, and she's very, very much happy after the arthroscope. Now, the thing is that she's very worried when this pain or this motion can be restricted again. I mean, when it's going to restart again. How much relief is it given it for? For how long? What's the duration that it gives this?
This is very difficult to answer because it's very individual. Usually, we don't have studies about the situation after decompression or arthrolysis of a shoulder problem in RR. It depends on the distribution of the synovitis. I think in my experience, I think you have, it was a total synovectomy of the joint with an improvement of the range of motion completely. It could be forever. Yeah? It depends on the distribution of the synovia and on the grade of resection. If it was a total resection, you have good results.
Now, any questions for Professor Ashraf? Very nice presentation. Yes, go on.
So first of all, Professor Ashraf, let me thank you for your presentation, because it's the first time that I listened to an endocrinologist saying, should we really treat thyroiditis or not? Because, you know, many times I find this intolerable that endocrinologists are not treating thyroiditis. So which is the treatment? I don't have a clue about this, but I see patients completely abandoned until they arrive to hypothyroidism. So do you have any suggestion for the treatment of thyroiditis per se?
Thank you very much. First of all, I just want to say that the idea also for this one was initiated by Professor Badawi because we have some cases like this. Actually, thyroiditis, it may start as Graves' disease, hyperthyroidism, then goes into hypothyroidism. So we need to, first of all, to know this is starting as hyper or hypothyroidism. This number one. So if the disease, the autoimmune disease, yes. So if it is starting as hypothyroidism, so we'll give the treatment for L-tractane therapy. This is what is available now. But and if there is hyperthyroidism, we are giving some medication to suppress the thyroid gland activity. But my point was that we need further question, because I know that there are predictors for the thyroid gland. It will be disrupted or it will be burned. So my question: can we prevent the disease progression? And I think this question needs to be discussed between the rheumatologist and the endocrinologist to see what is the best option in such case, instead of just waiting until the gland is totally burned and then give hormone replacement therapy. Because if we start treatment early and we have predictor for this one, it might help to save the gland, the thyroid or suprarenal for the patient. And then at that time, we'll see it is beneficial or no. So maybe, I don't know, it needs a further study to use, for example, steroids early to suppress this autoimmune process or no. Then we'll see the outcome. But it needs further workup. Thank you very much.
Yes.
Yes, so Dr. Ashraf, again, thank you for very interesting presentation about that. But speaking about autoimmune diseases, organ-specific and organ non-specific, personally, I do not believe that there is any organ-specific autoimmune disease. All autoimmune diseases are systemic from the start. And the question to Dr. Badawi and to Professor Marco and to you also about when to interfere. As you said, a person has got thyroiditis and it is stable now as myxedema patient or hypothyroid, and we are on replacement therapy. But the patient has a lot of systemic manifestation. Shall we go to give steroid or not? Patient with ulcerative colitis and is stable as ulcerative colitis, but he has a lot of systemic symptoms. Shall we start anti-suppressive treatment or not? The autoimmune diseases are, by their nature and definition, are intermingled and complicated. When to interfere? When can I justify giving steroid?
Marco, you go first and then I'll follow you. I interfere as early as possible. I don't want to lose the gland. I don't want to lose the other systems of the body. So I interfere from the beginning and aggressively.
Personally, I don't think that there is any use of steroid or immune suppression for treatment of autoimmune endocrine disease. Endocrine glands are very delicate, and if there is autoimmune attack, you would not help. It's like the tsunami. Whatever you do, you will not help. If the autoimmune attack starts on an endocrine tissue, it will be lost. It will be burned. There is no time and no benefit from trial. And this was proved with type 1 diabetes. When they tried with autoimmune aggressively, they failed. And even with thyroiditis, in the start, thyroiditis commonly having hyperthyroid. The tissue is inflamed and getting all its hormones outside. There is no way to think about. Now I think with our available immune suppression now, it's very difficult to fight that.
These cases I co-manage. With an endocrinologist. I refer the patient to him, and we manage the case together. Usually we agree. I start my therapy, and he starts his therapy, and we co-manage the patient together. Nobody takes the decision on his own, and this is a very typical example of co-management.
to give comment, Dr. Ghunaimi. I said it is traditionally divided into organ-specific and non-organ-specific, but this classification is artificial. And I mentioned this one clearly in the presentation. This is artificial presentation, and the aim of this presentation is to show the overlap between the non-organ-specific or organ-specific. This is very important, this number one. So it is pointed out clearly it is artificial. Number two, regarding the management. Our target for the management, if we can keep healthy gland early, we did not say we have to wait until the gland is totally burned. We just put in a question, like for example, in autoimmune disease, we have only diabetes prevention trial, which showed for autoimmune disease, which shows some improvement. But for other glands, there is no prevention trial. So it deserves that we can make trial. If we can save the gland to the patient instead of waiting until the gland is totally burned and then you give hormone replacement therapy, we don't know which will be more better, healthy gland or to wait until the gland is destroyed and to give hormone replacement therapy. It just needs further recommendations. Thank you.
Marco.
I totally agree with you, Samir. And the question I have, I mean, it's not a question, it's just a consideration in my experience, that behind a thyroiditis, there is always something behind it. We have discovered celiac disease, arthritis depending on celiac disease. The celiac disease is inducing arthritis, Sjögren's syndrome, thyroiditis, diabetes 1. And behind all this is just a celiac disease. So we know that there is something behind. We don't know what. We don't know what, because saying thyroiditis, we don't say anything, because there are many different kinds of thyroiditis, and the association with other signs and symptoms and hidden diseases is very important to be, like hypoparathyroidism, for instance, is very important. So when you see a thyroiditis, you know that you have to investigate the whole subject, not only stick to this, because if not, you will lose all the other and try to understand what really is going on. It really is going on. So, you know, thyroiditis, I'm very sorry to say, but our endocrinologists, I'm speaking about our Italian endocrinologists, they don't consider it. Just give some levothyroxine and that's it. They don't investigate and don't enlarge the view of because this is a systemic disease. Usually, we as a rheumatology, we see them even in the early phase. Why? Carpal tunnel syndrome, chondrocalcinosis, attacks of microcrystal disease. Then comes the hypercholesterolemia, cardiovascular disease, and atherosclerosis. So, and depression, because depression is one of the mainstay of thyroiditis. Hyper-irritability and then depression. It goes up and down. So I'm not a specialist, but in the last 23 years, I have seen a lot of thyroiditis. Usually, out of 10 patients, 3 or 4 have a thyroid problem. Now we see patients coming from Eastern Europe, from Ukraine, Chernobyl, and I have to tell you, almost all of them have thyroiditis, almost. So I don't know if this is radiation-induced or who knows what, but there is something, obviously, that in our population is striking enormously, because this is probably one of the most frequent diseases we have in women, in young women, mother, daughter, sisters, you know, it's impressive.
Thank you, Marco. I think the routine I'm doing in my clinic now, when I see a patient for the first time, I do thyroid function test, T3 and 4, TSH, hepatitis A, B, hepatitis B and C. I do parathyroid, and many patients, they are not symptomatic, and I discovered that they are either having hepatitis C positive and they don't know, or they have diabetes and they don't know, and they have a thyroid disease and they don't know. Any other questions? Ashraf Astala? Go ahead.
If you remember, Professor Badawi, one of my patients is Hashimoto's disease. I'm just, because we have many cases like this recently, not many, few cases like this. And these patients with Hashimoto's disease, I just wanted to screen the other systemic autoimmune disease, because patient clinically is not euthyroid, but biochemically euthyroid. And once I started to look for the other systemic autoimmune disease, I found ANA is high and is increasing. And one of them reached to more than 1,200, means 1,200, something like this. And when I discussed the case with Professor Badawi, after 2 weeks of taking low-dose steroids, the patient told me, I am totally different person. Although the same thyroid function was normal Hashimoto's, but starting low dose, and after 2 weeks, she's a miracle lady, and she told me I am totally different person because we just looked for the association for other autoimmune disease. And this has happened with many of other patients also as well.
Professor Schmitt, thank you very much. Very interesting presentation. I have a question. This patient with the hip disease, you want to buy time because he's young. Do you think resurfacing of the head of the femur can be buying time till he had an arthroplasty at the end?
I don't think so. I think we just can improve the pain, we can reduce the inflammation inside the joint, but we don't have the possibility to recover the cartilage surface without a replacement or so. I hope that we have a little bit of time with this patient, because he had the first information about his disease 3 months ago, so he didn't agree in a replacement or something like that. Also, not in just a head replacement, the cup prosthesis. So I hope that he can walk better now. I saw him last week. I hope that he will have some months of better range of motion and less pain, and then maybe we can prepare him for the next step.
But I think this patient should be medically very, very well controlled. Otherwise, if he's flaring and if he's walking more, he will damage the cartilage more. And I think this is a very critical case because he's a young chap. Any other questions? One of my nightmares with my patients is the elbow. Yeah. The elbow.
Yeah,
I'm sure it's your nightmare as well. The elbow.
And even for every orthopedic surgeon, for the orthopedic surgeon, it's also a nightmare because it's you cannot treat it arthroscopically totally, so you always have to do it open. And all patients with an elbow problems have a problem with the range of motion after that. And that's all the biggest problem in the orthopedic field. Yeah.
Okay, any other questions? Akram, you want to ask?
No, I mean the rate of the disease to the big joint compared to the elbow is 1 to 100.
Yes.
Yeah. Yes. So you see one elbow and 100.
Yes.
You're getting much better than before. Yes. This, you know, Mr. Zdira, this is why we have meetings. So that Akram will speak the same language with us. When I send my patient. No, I do. Okay. Okay. This is why I've been very careful. Any other questions? First, I would like to thank the audience for staying with us till the end. I'm sure they are very tired and exhausted. The last session was the best session, one of the best sessions, really a lot of discussion.